Good afternoon and welcome to today's presentation, A Process of Change, Integrating HIV, STI Prevention and Primary Care Practice. My name is Jennifer Trujillo and I'm the Substance Use Disorder and Special Populations Program Manager at the Nevada Primary Care Association. Nevada Primary Care Association helps community health centers provide exceptional medical, dental, and behavioral health care to Nevadans by advocating policy changes, providing training and technical assistance, and creating economies of scale through program management. For more information regarding our PCA or to subscribe to our newsletter, please visit us at nvpca.org. This presentation is a partnership between the Nevada Primary Care Association and the University of Nevada, Reno School of Medicine, AIDS Education and Training Center program. I just wanted to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over logistics and housekeeping items for today's presentation. Please type your name and organization into the chat box. It's nice to see who in the community is attending this presentation today. During the presentation, please mute your phone or computer so we do not have feedback or background noise. Also, please do not put your phone on hold or we'll hear your hold music. You will have the opportunity to submit your questions to the presenter by typing your questions into the chat box. You may send in your questions anytime during the presentation. Questions will be collected and addressed during the Q&A session at the end of today's presentation. Today's presentation will be recorded and slides will be available to participants. I will turn over the presentation to Mary Carls, Program Manager for the Pacific AIDS Education and Training Center, Nevada, to talk about her presenter and organization. Mary, please take it away.
Thank you, Jennifer, and thank you also to the Primary Care Association for partnering with us to have this presentation today. Just to give folks who are not familiar with our AATC, here I just wanted to give a brief introduction as to who we are. So we are part of the HRSA-funded Ryan White program. We are, you can see there's several parts there that fund different areas of Ryan White services. We are funded by Part F, which is the AIDS Education and Training Centers. There is one in every state, and we are divided regionally. Next slide, please. So these are the regions divided. We're in what's called Region 9, or the Pacific AIDS, or Pacific AATC rather. That includes California, Nevada, Arizona, and Hawaii. So while we're based in Nevada, we really have national resources at our fingertips, as well as regional training and education resources. Next slide, please. And this just gives you, again, we're what's called a local partner. So there, again, are the states that are included in our region and the local partner areas. You can see we have one in Nevada and Arizona. California has several, and there's one located in Hawaii. Next slide, please. And then this is just gives you a program overview, what our mission is, which is to increase the number of healthcare teams that are educated and motivated to care for individuals with HIV, increase their access to care, and thereby reducing HIV-related health disparities. And overall, really, our AATC program is charged with expanding the number and ability of healthcare professionals and organizations to provide high-quality HIV services that, again, increase access to healthcare and decrease the health disparities. Next slide, please. And this is just a menu of our services that and things that we provide. We provide targeted trainings, specifically kind of around those topic areas. We also provide targeted trainings by request and need, either by organization, or sometimes we do group trainings such as this, or statewide trainings. We do work with several annual conferences, the Ryan White Provider Summit, the STD Update, which we now have twice a year, one in the north in Reno, one in the south in Las Vegas. ANAC annual conference, Association of Nurses in AIDS Care, and then our biggest annual conference we have is an annual Autumn Update, which is a HIV networking for care. We provide technical assistance around those areas that you can see there. We work specifically with Huntridge Family Clinic in Las Vegas, practice transformation. And then we also we're working on a Nevada clinical preceptorship here in our state, which we hope to launch a pilot at the beginning of next year. And then finally, we also do, as we are statewide, we spearhead statewide initiatives that are involved in the ending the HIV epidemic or getting to zero. Next slide, please. And then, so with that, this is actually a global initiative that has become national and into states. And so getting to zero, meaning we will get to zero new HIV infections, zero deaths from AIDS-related illnesses, and zero discrimination. And so a lot of this presentation today is really ultimately getting to the end goal where we can end the epidemic in our state by providing screening and testing, implementing that in our clinics. Next slide, please. So with that, that's my information and my director, Jennifer Bennett's information on our slide. We also have a web page through the medical school at UNR, so you can check that out. And without any further ado, I would like to introduce our medical director, who is our speaker today, Dr. Roseanne Sugay. She is currently a staff physician at UNC Wellness Center and the medical director for Nevada AETC. Dr. Sugay transitioned into her position there after having served as clinical physician and medical director at the Sexual Health Clinic and Ryan White program at Southern Nevada Health District. With her public health background, she makes every effort to recognize and try to close gaps in health disparities in her practice. And so it gives me great pleasure to introduce Dr. Sugay. So please, Dr. Sugay, turn it over to you.
Thank you, Mary. I just want to make sure everybody can hear me and see my screen before I start. So if somebody could just say yes on the chat box.
Yes, we can.
Awesome. Okay. All right, so today I'm going to be talking about trying to integrate HIV and STI prevention in primary care practice. And it looks like it's a small group. I was wondering if you are on a computer, if you could just type into the chat box kind of where you are or what you do in terms of HIV care or prevention, just so we have a general idea. Since it's a small group, I figure we can get into the weeds a little bit and make this a little more practical. And while you're doing that, let's see, I have no disclosures, and these are our learning objectives. So we want to be able to identify key staff to implement HIV prevention techniques, list different tools used for quality improvement, and explain the importance of data to monitor changes in our practice. So just kind of to circle back in a talk we had about a month ago, the importance of HIV screening in terms of ending the HIV epidemic is because we have estimated that about 14.5% of people are still unaware of their HIV status, and 37.5% of new HIV infections are actually traced back to that 14.5% that don't know their status. I see we have a lot of clinical pharmacists on the line, and that is awesome because you all can help get some of this started actually. And Dr. Madison, who was one of our clinical pharmacists at the health department when I worked there, was also closely involved with some of our screening practices at that time. Can I also know if you could type into the chat box how many of your clinics actually do screening or what exactly you're looking for in terms of this talk? So even more than that other slide, more than 75% of patients who were at risk for HIV who saw a primary care provider weren't offered an HIV test during their visit. So this, you know, kind of if you're in the HIV world, we all think we're doing our job and offering screening, but the reality for most primary care clinics is that a lot of the patients aren't asked about risk and aren't offered screening, and I think this is why we're trying to encourage integrating HIV screening and STI screening into primary care practices. And step one, so before you even think about integrating whole new practices into the clinic, is a readiness assessment. So how ready is your clinic or your site? And so you want to take a look at resources and see what's already in place. You want to take a look at activities or processes, like what's currently done in your clinic. And then you want to see what kind of results you're trying to look for. I'm going to skip to the third part in terms of results. We're all going to agree that with the title of this talk, the desired goals would be either to offer HIV screening tests, offer other STI screening and treatment, or maybe even offer PrEP and PEP services, depending on your site. Just as a reminder, screening for HIV is all patients 13 to 64 years old, at least once in their lifetime and more often with risk. And it's up to 65 years old for the USPSTF. And again, so at least annually for all sexually active MSM and for anyone having unsafe sex or sharing needles. So the first step in readiness assessment is to look at your resources, and you want to identify who your administrative lead is, and that's the person who kind of handles all the back end stuff, who's going to do the contracts and budgets if there's any that need to be done, who's going to be doing the purchasing for equipment or test kits if you're going to be doing rapid point of care tests, who's going to be doing the community referrals, or do you have MOUs? If you're not a treating clinic for HIV, where would you send these patients? If you don't do PEP and PrEP, where would you send those patients as well? There's also the regulatory compliance involved, and so do you know the consent process for HIV? If you're doing point of care testing, what are the rules for getting the testing done in your clinic? Are you going to be advertising this new process that you're doing at the clinic, right? And so if we take a look at that advertising wise, I don't know if any of you are familiar with this website. So this talk is a little more practical. It's all the kind of information and resources you need to get HIV testing and STI testing and treatment done in your clinics. So this is a CDC website called Get Tested. And if you type in kind of a Las Vegas zip code, which is what I did here, what you're going to see is a list of places that come up. So UMC is one of them, AHF is another, Nevada Health Centers is already there. So check to see this list and see if your clinic's actually in this list. If not, you can see there is on the top right of the screen, if you were to go to this website, you can actually register your clinic if it's not registered and you're offering, and it lists, so you can list what you offer, whether it's HIV testing, STI testing, hepatitis, vaccines, and the like. And if you're not doing screening in your clinic or your site and you want to do it, then this would be the website that you would need to go to for information. And this is for HIV testing by the Nevada Human Health Services. And it talks about how all the steps you need to do if you're only doing waived HIV testing or point of care testing. Next step in the readiness assessment for people is identifying a clinical champion. So if you don't have buy-in from the actual clinical staff who's going to do this, the testing and screening is not going to work. Buy-in from the clinical staff will also better integrate the practice in terms of clinical flow. And then you also want to make sure that it meets standards of care. And so definitely getting your clinical staff involved is important. And you also want to identify the clinical staff that are going to have to deal with these changes, whether it's an MA or an LPN or an RN. Apologies, I should have put PharmDs as well here because they do help. Social workers, health educators, case managers, or whoever resources you have in your clinics or sites. So this is from the Institute of Healthcare Quality Improvement, and you can actually go to their website. The link is in the bottom of this this slide, and it's a quality improvement team member matrix. So you identify your project sponsor, you identify a day-to-day process owner. So you kind of list out the people who are going to be involved in the project, what they're going to be doing, and you kind of there's check-off boxes to see what they're contributing to this new initiative that you are doing. In terms of infrastructure, materials, and information technology, you're also going to have to decide if you're going to be doing HIV testing, whether you want to do a point-of-care test versus a lab send-out. Do you have a lab currently in place? Who will be doing the lab testing? Do you send out for labs, or do you collect samples? Again, I saw a couple of PharmDs on the call, and depending on whether you're a standalone pharmacy or not, there's some interesting information out in California where pharmacies are more involved in terms of doing PrEP and STI testing. And certainly with Nevada loosening their requirements for standalone HIV screening, this is a possibility. If you want to do the work to get this done, you can actually potentially be offering HIV screening tests at a pharmacy as well. Next slide. So in terms of doing point of care versus outsourcing your lab tests, some of the pros and cons to think about. So one of the pros, obviously, you get immediate notification and counseling. You get a test result right on the same day of service. For outsourcing, there's minimal change in the clinic, right? And the confirmatory testing is done automatically by the lab, but the turnaround's a little bit longer. In terms of point of care, there's more change involved in terms of clinic flow because you're integrating a new point of care test. And in terms of the testing technology, the window period for your HIV test might be a little longer with a point of care test than the blood tests that you can order and send to the lab. And in terms of cons for the outside lab, again, there's a delay in the test result, and then it becomes a challenge to notify any positives that you pick up from this test. This is a reference for ways to choose an HIV test. And really, the things you have to think about are you have to be aware of the window periods, and you have to define the situation. Are you screening versus diagnosing a patient? Are you going to be doing PEP, or is the patient on PrEP? And those are things you have to think about when choosing a test, a testing technology. So as a reminder, I talked about this in our previous talk about a month ago. When you're using an HIV test, you have to think about window periods. And window period is the time from when a person becomes HIV infected to the time that a serologic antibody test becomes positive. And to clarify from the last talk, there's also something called an eclipse period. And the eclipse period is the time from when a person becomes HIV infected to the time that you can detect HIV virus or viral PCR positive in the patient. This is another way to take a look at it in terms of eclipse periods and window periods. Obviously, the one that takes the least amount of time from time of infection is an HIV RNA, kind of like a viral load. And after that, you can see the 4th generation test is the first antigen antibody here. If it's lab-based where you send it out, the window period is a little bit less than if you did a point-of-care test in clinic. And so you're talking maybe a 5-7 day difference. And here's another way to visually understand the idea. The first blue line is when you see viral load, and in the acute illness, you start to see a rise about a week, 10 days into it. And then you see the P24 antigen, and you see the serologist as well. So this tells you kind of when your tests become positive for the first time in terms of number of days. So from a practical standpoint, there are multiple HIV point-of-care tests available, and I thought I would consolidate some of that here for you so that if your clinic doesn't do point-of-care testing and you opt to do it, you have all the information in one place. The ones I'm familiar with that we've used at the health department is the Determine HIV 1-2 antigen antibody combo test. It's the first one pictured here. The time to result is 20 minutes. So then you kind of have to think about your turnaround time and how it'll affect clinic flow. But this is a 4th generation test. So the point of care tests, this is one of the ones with the shortest window periods. And then we've also used INSTI at the health department when I used to work there. And the nice thing about the INSTI is it's less than 2 minutes for you to get a result. So you almost have an instantaneous screening result. This is not a 4th generation test, but again, you can see the sensitivity and specificity of the testing is still quite high. The window period is just a little bit longer for this test. These are the other tests available in the market. I recall using Clearview a few years ago. Again, a good test, 15-minute turnaround. Again, window periods are not as long. One of the other things you would probably have to be looking at is cost of the various testing methodologies and how that would affect your budget. And these are other tests. So there's the Unigold and the OraQuick. So OraQuick, actually you can do oral fluid instead of doing a finger stick and blood. So this is another option, just depending on where you're doing your testing or if you don't want to be doing blood tests. Again, window period is much longer, sensitivity and specificity little bit lower if you do oral fluid, but you can actually do an oral swab as an option. And again, just to beat the point in terms of window periods, these are the different window periods in terms of when your testing will be positive. And this is for the 4th generation test, right? So the first bar is that by day 13, 25% of people with HIV will have a positive test. By about day 17, 50% of people will have a positive HIV test from time of infection, and so on. So you can see that by day 44, almost 100% of people who have been infected with HIV will be found to be positive with a 4th generation test. And so that's the full window period for your 4th generation antigen antibody test. Again, just as a review, to diagnose and screen all those point of care tests, you're going to get an HIV 1-2 antigen antibody screen or an HIV 1-2 antibody screen, depending on what generation testing you're doing. If it's non-reactive, then it's either they're in the window period or they don't have HIV. If it's reactive, though, you can't quite tell a patient that they're HIV positive at that point. Please remember that you have to do an HIV 1 and 2 confirmatory test. And if that's reactive, then they have HIV. If it's non-reactive, you need to kind of have a tiebreaker and order a qualitative nucleic acid amplification test or kind of like a viral load to see whether the person actually has HIV or not. If you're looking at clinic flow, this is a patient care model with integrated rapid HIV testing. This is actually from 2011, and as you can see, it depends on your clinic and how you want to do it. But would be a good idea to kind of figure out what your flow is and spell out where you're going to be putting in or integrating routine HIV screening into your current clinic flow. As you can see on the right side in the routine HIV screening clinic flow, it's still Western blot. Like I said, this is 2011. I'm going to show you the next screen where we change it. And really, if you're doing point of care testing, here are a couple of changes to the workflow that I would suggest. If it were reactive, you would have to draw a confirmatory. That wouldn't be a Western blot, right? So it would be the new confirmatory for the 4th generation antigen antibody test, which is a differentiation test. And then you schedule a follow-up if the person's confirmatory positive. Always a good idea to let the health department know, counsel the patient, and ensure that the patient has referral services. Here are community resources for referral services. It is not complete. I've only put UMC and the health department because those are the 2 places I've worked at, but there are a whole lot of other community organizations that do take care of HIV and do an awesome job at it. If the testing is indeterminate, know that you also need qualitative PCR testing. And I put this purple box on the side about offering or referring PrEP services. If that is something your clinic is going to be doing, then certainly anybody who comes in for an HIV test or an HIV screening test and you assess risk and they're high risk, it would be a good idea to either offer PrEP services or refer them to a clinic that does. In terms of counseling and education material that you would need, you'd have to look at your clinic and see if you have any information on HIV testing, on risk reduction, or on PrEP and PEP. What is it, or where can you get that service? So again, this is a website out of the CDC, and the link is up top. And don't reinvent the wheel or try to create your own resources. This has a whole lot of things you can download and print. Nice thing about CDC's website, they actually already have it in English and in Spanish. So if those are the two most common languages that you have to deal with in your clinic, that's already kind of neatly done for you. This is the wording and kind of the verbiage we used at our clinic. We started to do opt-out testing at UMC Hospital, and we just kind of put up these signs in the ER: expect the test. HIV is routine testing like glucose checks and lipid profiles, and the worst HIV status is unknown. And this is all from the New York Public Health Department of Health toolkit, and the link is in the bottom of this slide. Last but not least, in terms of information technology, you have to assess whether you're on paper chart versus electronic health record, and if you're going to integrate it into your EHR. So if you're a paper chart, it's a little bit easier to implement. You make a form, like another form to put into your charts. And if it's an electronic health record, can you put in those question prompts into your system and build it in automatically so that whoever is rooming the patient, or if your workflow has this done by your front office, that the questions are readily available and whoever's responsible gets prompted correctly to do the screening. And this is just kind of the Institute for Healthcare Improvement. There's lots of good information in terms of developing reliable processes if you are going to be starting this process from the start. So in IHI, they talk about things you can do in terms of when you're planning. First, you have to segment it. What are you trying to do? Who are you trying to reach? Visualize what your current clinical flow is, and then simplify it, standardize it, like who would be involved, what, when, where, and how, and then develop a backup plan just in case the first plan doesn't work. So, for example, if you visualize what's going on in your clinic, is the patient groomed by support staff, does basic history and vital signs, and then the physician examines the patient, orders the test, and then lastly, the patient is discharged by support staff. So if you segment that, or standardize and simplify it, if your patient is roomed by support staff, so who's doing it? Support staff. Are they going to be offering the HIV test now? And when are they're going to be doing it? Is it during grooming, or is it going to be done in the triage room? Are they going to do the test point of care, or put it in a lab slip as an order and pre-check it for the physician? So those are things you can think about. And if the support staff doesn't do it, what is the backup plan? Yeah, so if the rooming people don't do it, can the discharge people check again and offer the HIV test on discharge as well? In the exam room before they send the patient home. And again, the question is, would they at that time be doing the point of care testing in the exam room, or putting it on a lab slip and sending the patient out to an outside lab? And after that, you want to do continuous quality improvement. So it's not enough to just set up a process. You want to make sure that the process is working. And so you do a PDSA cycle as one way to keep track of what you're doing. And so what are you trying to do? How will you know that you made an improvement, and what change can you make if you didn't quite hit your target? Again, this is from the IHI. It gives you a worksheet to kind of use in terms of what kind of outcome measures are you looking at, and process measures and balancing measures. And from a quality improvement standpoint, you want to make sure that you're asking, well, what your target is, whether it's 50% of patients are screened, 100% of patients are screened. You want to put in that metric and then see if you reach it. And then you keep doing the cycle of planning, doing, studying, and acting. If you don't hit your metric the first time, figure out what went wrong and then go from there. And so that's for HIV screening. In terms of STI prevention and why, as a reminder, these are our state rankings by rate of new infections in Nevada. So Nevada is number 1 for syphilis, number 2 for congenital syphilis, number 12 for gonorrhea, and number 14 for chlamydia in the nation. And this is why STI prevention in primary care clinics is important. I can't not talk about integration of STI care into a primary care clinic without touching briefly on sexual orientation and gender identity. There have been multiple studies, and some from Fenway, saying that a lot of our LGBTQ patients are uncomfortable having these conversations with their primary care physicians, and they want to ask, but they don't. And doing sexual orientation and gender identity identification at the start of a visit actually helps dispel some of that discomfort. And so this is the genderbread person. And just as a reminder, gender identity is not the same thing as expression, and it's not the same thing as sexual gender, and not the same as sexual orientation. So this kind of breaks it out kind of nicely, where sexual orientation is kind of who is a person attracted to, and gender identity is a person's womanness or manness. Doing a sexual history is also important in terms of defining a patient's risk. And as a reminder, this is an acronym that's quite easy to use. You could do the 5 Ps, and you can ask about partners, practices, pregnancy prevention, protection from STIs, and a past history of STIs. So from a partner's perspective, you want to ask, do you have sex with men, women, or both? You can ask how many partners, whether it's one or more than one, and if they do have other partners. In terms of practices, you do need to ask what body parts are used, and normally it's you want to introduce the topic. You just kind of say, I screen all my patients because it changes what tests I would be ordering, and do you have sex with men, women, or both? Have you given or received oral or anal sex? And if they don't understand, then you can anatomically just describe the sexual practices you're talking about. Another risk factor the CDC does like to ask for is if the patient or a partner has ever exchanged sex for money or drugs, which is actually a risk factor for HIV and STIs. And also intravenous drug use is another practice. In terms of pregnancy prevention, what are you doing to prevent pregnancy? Protection from STIs and a past history of sexually transmitted infections is also important. As a reminder, screening for chlamydia and gonorrhea is at least annually for all sexually active women less than 25 years old. For women who are older than 25, you want to screen them if they have a risk, and the risks are more than one partner or a partner diagnosed with a sexually transmitted infection. You also want to screen all sexually active men who have sex with men. As my previous discussion, it is really important to do extragenital gonorrhea and chlamydia site screening. As a review of previous data, 73% of positive pharyngeal gonorrhea tests would have been missed if all we did was a urine gonorrhea chlamydia screen. 71% of positive rectal gonorrhea tests would have been missed. 92% of pharyngeal chlamydia tests would have been missed if all we did was a urine. And 88% of rectal chlamydia tests would have been missed if all we did was a urine screen. So again, this is why it's important to ask for practices when you do the 5 Ps in terms of STI screening. In terms of questionnaires, this was a form that we created when I was still working at the health department, and we were trying to encourage other clinics to screen. And we were trying to convince them, hey, it's not so difficult to to screen. It's only 3 questions, and so this was a screening assessment that we had both in English and in Spanish. And really, instead of even doing the 5 Ps, it just asked 3 questions. Have you had any sex? Have you given oral sex to a male? Have you received anal sex with no condom? And kind of in the bottom, depending on how they answered, it would tell you whether you needed to order any other tests or which tests you needed to order. These were also graphics that we created at the health department at that same time. And this is for clinics where people are uncomfortable collecting the swab. So they've actually done studies, and the results have been comparable, whether it's a self-collected swab or a provider-initiated swab. So we did these self-collected infographics so that staff could just show patients, hey, you can collect an anal swab yourself, or you can collect the throat swab yourself, and send them out for testing. And so this was the anal swab in Spanish, the first one was in English, and then these were our infographics for throat swabs. Again, useful things to have, and that's why I included it in the slide set if you need it for your clinics. Other housekeeping kind of important detail things to remember, just so all the testing and collection you're doing don't go to waste. A urine specimen typically is collected in this Aptima urine specimen tube, and this just kind of gives you an instructions on how it's done and when your specimen is rejected. And this is the one for the swabs. It tells you which swab you need to use, and so you would be ordering a multi-test swab specimen. There are different kinds of swabs. There's one for cervical, there's one for urethral swabs, but really if you order this multi-test swab, this is the one you need for throat and anal swabs. And this just tells you how to label it. I can't tell you the countless number of times our specimens have been rejected because they said the labeling was incorrect. So it seems kind of silly to put this in here, but I thought I would because it does happen quite a bit. And then in terms of screening for syphilis, again, as a reminder, you want to do it at least once during pregnancy. Definitely all pregnant women, as you saw from our previous slide, we're pretty high up there in terms of congenital syphilis cases in Nevada. And definitely at least annually for sexually active MSM, and sometimes more often than that. As a reminder, the natural history of syphilis, you are exposed to Treponema pallidum, 10 to 90 days for a primary chancre to occur. Just remember that with or without treatment, that painless chancre will disappear. 3 to 6 weeks later, somebody can have a non-specific rash. Although classically diagnosed with palmar and plantar lesions, it could almost look like a drug reaction. And I remember I had a patient who we had just started HIV medications on, and he came back with a rash, and had seen one of the ancillary staff, and they had come up to me saying, oh, I think this person had a drug reaction to his new HIV medication, and that non-specific rash actually turned out to be syphilis. So definitely asking history at any given time is important. Secondary rash, with or without treatment, will also disappear. And then when the person doesn't have any signs or symptoms, the first year from exposure from syphilis is called early latent syphilis. 25% can relapse back to secondary syphilis. If it's been more than 1 year where a person was exposed to syphilis, then it's called late latent syphilis. Untreated, 30% will eventually evolve into tertiary syphilis. Just as an aside or a point of clarification, we hear a lot about tertiary syphilis. It's kind of like when you talk about Napoleon Bonaparte or people in the 1800s who went crazy because of syphilis, it's tertiary syphilis, and sometimes people confuse that with neurosyphilis. And those are actually two separate processes. Neurosyphilis, ocular syphilis, or otic syphilis that we're seeing right now can actually happen anytime during exposure to Treponema pallidum. So it can happen anywhere within the first year onwards. And is a little different in pathology than the neurologic changes we see in tertiary syphilis. So things to remember, about why it's important to screen for syphilis. Nevada has the highest rates of syphilis in the US, so definitely always include it in your differential. Again, ocular, otic, and neurosyphilis can happen at any time, so it's not the same as tertiary syphilis. And the third one is really important in terms of helping your public health colleagues, is a day of treatment RPR. And then this will help you determine treatment adequacy. A lot of times, especially in outpatient clinics, this becomes an issue because the first time you order the syphilis test, it takes a while for the results to get back. It's a week later when you get the test results. You see that it's positive, you ask the patient to come in for treatment, and a lot of times you just give them that shot of Bicillin, and the day of treatment RPR gets missed. And a lot of times in primary and secondary syphilis, that titer continues to go up in that week difference. And it makes it a little bit harder to determine treatment adequacy on the back end if you don't have how high that person's RPR truly was on the day you gave them the treatment and shot of penicillin. Just as a reminder in terms of diagnosis of syphilis, a lot of places now use the reverse sequence syphilis algorithm where you order an IgM IgG test first. If that's negative, they don't have syphilis. If it's positive, you then order an RPR. If the RPR is positive, they have syphilis. If the RPR is negative, then you have to order a tiebreaker. This is kind of like what you do with your HIV tests, right? And the tiebreaker is an FTA or a TPPA test. If that's positive, you diagnose syphilis. If it's negative, then the person does not have syphilis. Understand that the window period, so to speak, of syphilis testing could be as much as 1 to 3 months in terms of when they have primary syphilis. Some of your initial testing could all be negative. So at that point, it would be more of a clinical diagnosis if all your testing is negative. Again, how do you treat syphilis? Please make sure if you are ordering Bicillin for your clinic, that it is only Bicillin LA that you use. Bicillin CR does not treat syphilis the same way. As a practical standpoint, I kind of put all the STI screening tests from the different commercial labs available in Nevada into a couple of slides just to help out. So it's CPL, LabCorp, and Quest, and these are the lab codes you would use to order extragenital gonorrhea, chlamydia screening, syphilis screening, HIV screening if you're opting not to do point of care testing. Also interesting is that LabCorp and Quest actually have PrEP baseline and PrEP follow-up testing where they've actually bundled together the tests you would need to do it. I tried to look at CPL, but they don't have a bundled testing order. I thought this would be very useful information if it is not something your clinic is doing at this point in time. And so in conclusion, you have to identify key stakeholders, both in the administrative and clinical levels, to be able to implement a new initiative. And you can use various tools to help with your change process, whether it's PDSA or using a flow chart or doing a readiness assessment. Those things all help. And then you have to make sure that whatever new process you have in place is working. And so data collection is important, and it's also more often than not a grant deliverable. So definitely important to be able to collect your data and track your progress in the program. And that's it. So I wanted to end with a saying, don't let perfect be the enemy of good. Depending on where you are or where your clinic is in this whole process of including HIV and STI prevention and care, just take baby steps and keep working at it. There's always room for improvement. I mean, even where we are at Wellness Clinic, where we've been treating HIV patients for some time, there's always room to do more things and improve on our processes as well. And that's it. Any questions from anybody?
If you have questions, you can raise your hand and I can unmute you, or you can type it in the chat box.
Yeah, I mean, I really wanted to ask if there was anybody in the audience who's like in the process of like starting a program where there's nothing going on in their clinic right now, and they're just in the starting process. I see a comment from Michael over at AHA and encouraging other PCPs to be comfortable about asking a sexual history and doing a better job of screening. Yeah, so that's kind of all of us wanting to do that, and really it's just kind of having those conversations. I usually, if you're at your PCP's office, that's one way to do it. You can ask about, hey, you didn't even screen me for sexual history. Having kind of all the other details neatly tied up in a package for them also helps when they do say, oh, I don't have time, or I don't know which tests to order. And that's kind of why I put them in the slides. Like, okay, these are the lab orders you need done. Here are the infographics for your patients if you're uncomfortable collecting it. Here's a written questionnaire you can use if you don't want to ask the questions. So those are kind of starting points that have worked. Sarah says, you work at the free clinic, you volunteer at the free clinic, and you're in the middle of initiating a program. So great. All right, Sarah, are you going to be doing just HIV screening or HIV STI screening, or what is the free clinic looking to do? We plan to implement all labs at the clinic to send out. Of like Quest labs and things help you out in terms of, or Quest CPL LabCorp, like the list of which tests to order is helpful. Yeah, there's some growing pains when you start that in terms of just making sure the labels are correct and making sure each place has the correct specimens, because there are sometimes some variations, and you find out when your test gets rejected by the lab. But that's awesome to hear that you're going to be doing all that testing, Sarah.
We do have a question from Annie. Annie, you just need to unmute yourself. You're unmuted on our end.
Oh, Annie's asking if we're able to send the slide deck. I find it very helpful to teach residents who are in HIV track and family practice residency. Sure, absolutely. I submitted one to Brandy. I'm not sure. Did you just want to? I don't have your email, so I don't know if we send it out through Brandy or through Mary.
Yeah, I'll send it out to everybody.
Your email now. So yeah, I can forward it to you. Where do you work, Annie? Oh, nice. We have somebody from California. So apologies, it's Nevada. Some of it's Nevada information. I guess you'd have to switch it out a little bit, but I'm glad to know it'll be helpful. I have always wanted to start a point of care HIV testing clinic. Yeah, so I don't know what the rules are in California. For a little bit, it was even in Nevada, it was kind of like considered a moderately complex lab. Just kind of the clear regulation was a bit of a pain, and so not a whole lot of people were doing point of care testing. And then a few years ago, thank you to our friends off at AHF that actually lobbied with legislation to change some of the rules in Nevada to kind of allow more non-clinical workers or kind of community health workers to do HIV testing. And with that, it became easier in terms of regulations to get point of care HIV testing done. So I'm not sure what the rules are in California, but hopefully it's something you can do. It's always kind of a toss-up between the first two tests that I posted in the slide set. Do you want to do the 4th generation test, but it's a 20-minute turnaround, or do you just want to do the INSTI because it's only a minute? But either one would be awesome options. And you're welcome, Annie. Does anybody else have any questions?
I don't see any other questions, so we'll hand it over to Jen.
Thank you to everyone for attending today's presentation. You will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide feedback. I will be contacting a few of the attendees from today's presentation in the next 3 months regarding the impact and benefits of the presentation and to discuss what types of future training and technical assistance will benefit your health center. If you have any further questions, please contact me, Jennifer Trujillo, at jtrujillo@nvpca.org. On behalf of the Nevada Primary Care Association, thank you for joining us today and have a great rest of your day.
Thank you, Dr. Soge, for a good presentation.
Oh, you're welcome. I don't know if Mary's on the line to talk about the ATC. Okay.
I wasn't sure if you're, yeah, yes, thank you very much. It was a really good presentation, Dr. Suge, so thank you. I'm actually in the process right now of sending out our evaluation to the attendees. So please complete our evaluation as well. We value your feedback in order to provide more relevant training around this topic or any topics. We really value your feedback so we can continue providing that. And if you would like a CME certificate for this training, the evaluation is required. So do please complete that, and certificates will be emailed to you within the next 2 weeks. And thank you again, everybody, for joining us today.